Well, you guys want to go ahead and get started? We've got a few guys on here, and some other folks might join us. Got some pretty good cases, and I think I think Travis said they ran out of, of cases to show, so we just pulled some interesting stuff from our collection, and so we got 10 cases. If we get through, what do you guys have till about 7:45 or so, approximately?
Yeah, about that.
Yeah, we'll just get through as many as we get through, and then we'll save the rest for the next time. So somebody tell me about this one here.
Okay, this looked like this sort of like polypoid shaped lesion. Almost looks like it was maybe pedunculated.
Actually, I'm gonna,
or if it was just a punch.
Yeah, so it was basically a punch just kind of folded back on itself. It does look like a little bit of polyp, but I don't want you kind of going down a cul-de-sac there. So yeah, it's really not a polyp. It's just kind of a punch that, sometimes you do a punch and there's square biopsies and they look like a box. Sometimes if they have a lot of elastic tissue left, they'll sort of fold over like this. Or if they're atrophic, they can kind of do something like this a little bit.
Okay. Well, looking from the top down, the corneum looks like it's relatively normal. It's basket weave ortho, and then maybe a tiny bit of acanthosis, but not a lot of action happening in the epidermis to me. I thought more of the action was sort of in the papillary dermis. There was.
So you think it's an inflammatory process, right?
I think so, yes.
Good. And so there's something going on over here, isn't there?
Yeah.
Good.
It almost looked like it's not completely like obscuring the DEJ, but it does look like there's some sort of either like lichenoid or vacuolar interface dermatitis. But
good. Excellent. So when you look at the basal cell layer, even without seeing these little holes at low magnification, which you can just barely make out, but what else is wrong with this thing? You said it was acanthotic. I agree. It's a little bit sort of papillomatous and slightly thickened, but
there's no reedy ridges.
Good. Excellent. So whenever you see like effacement of the epidermal rhesia, that's something's wrong. That can happen either, people that get old, they gradually lose their epidermal rhedia and their skin gets real fragile. So that's one way. If there's any kind of inflammation there, that can, destroy it. If it's like a lichenoid process, lichen planus, et cetera, that can eventually lead to effacement of epidermal rhesia, lichen sclerosis. So yeah, if you see that, you say that's a clue that there's probably something going on at that interface there. It can happen in neoplasms too, like melanoma. You can like consume the basal cell layer in melanoma, and you can efface the rhedia. So that can be a sign of malignancy sometimes, but it's more commonly seen in an inflammatory process. So that's good. So you suggested that it was interface, and there's two types of interface that you also know about, right?
Yes. I think there are some more like vacuole looking type lesions here or areas here. So I would call it more vacuolar probably.
Excellent. This is a beautiful example of a vacuolar interface dermatitis. And what usually goes along with vacuolar alteration?
Are you thinking like dyskeratotic keratinocytes?
Yes. Good. So you got vacuolar alteration, dyskeratotic keratinocytes. Do you think this is an acute or a more chronic process here?
No, I think it's more chronic with all that pigmentary incontinence.
Good. Excellent. So yeah, good. Excellent. That's exactly right. Whenever you see melanophages, some other signs of chronicity, if you see some thickening of the collagen bundles, dilated blood vessels, Dr. Ackerman used to call that the fettuccine sign. So it's a sign of long-standing chronic inflammation of the papillary dermis. So and that goes along with a relatively few number of entities. So can you make a specific diagnosis just looking at this? I mean, can you say this is blank? Just looking.
Not necessarily, but my thought when I looked at this was like chronic fixed drug that's now that's not active right now, but I didn't see a ton of eosinophils.
Okay, that's one idea. But the main question I wanted you to answer, which you answered correctly, is that no, this is a reaction pattern. It's a chronic interface dermatitis with vacuolar alteration and with some scattered dyskeratotic keratinocytes. Can be one of a number of entities. So you can't just instantly say, this is blank if you see this. So then it's important because you don't want to, be a cowboy dermatopathologist and look at this and say, this is obviously this. I mean, I know a lot of guys that do that, but you can't do it. You can just basically say this is a reaction pattern to be seen in a number of different entities. Now, you mentioned chronic fixed drug eruption. What's one thing and you said one thing that's not good for it, namely the absence of eosinophils, but there's another thing that's not great for chronic fixed drug eruption here that you really would appreciate more at this power.
I don't know if it would be more like the cornea would be different, or there would be more like fibrosis of the.
Not necessarily, and this is the old, guess what I'm thinking. If you know the answer, great. If you don't, I'll, that's okay. But basically, when you get chronic fixed drug eruptions, they occur at the same site over and over again. Same site, boom, boom, boom. The melanophages get deep. You also see melanophages down in the mid-reticular dermis. That's a clue. You don't always. So this could possibly be a late-stage fixed drug eruption. I wouldn't say no to that. But if you really want to get a classic example of a chronic fixed drug eruption, you'll see the melanophages down here. So if you were just going to bet somebody for a Coke or something, you'd say, well, it might be a chronic fixed drug eruption, but it's less likely to be that because the melanophages are not deep and there are no eosinophils at all in the infiltrate. So that's just a clue. But what other things can give you this kind of relatively late stage interface dermatitis with melanophages in the papillary dermis?
I don't know if some
common. What's probably the most common one that we see in dermatology? Say Hispanic person comes in, they've got these dark plaques, bilateral axilla, maybe in the groin, and the
like
skin is dark.
Like EDP.
What do some people think EDP is?
Like lichen planus pigmentosis.
Like burned out lichen planus pigmentosis. That's probably the most common of all of when we see this. We probably diagnose that here a couple of times a day. I mean, it's actually relatively common that you'll see lichen planopilaris, and it's post-inflammatory pigmentary alteration, but you'll often see a little residual inflammation and maybe a couple of dyskeratotic keratinocytes, the Max Joseph spaces, Savant bodies, et cetera. So you may see a little bit of that. So that's probably the most common one. But what are a couple other things that could give you something like this? So you don't know. This would be like more of a multiple choice type question on a board. They're not just going to show you this and say, what's the answer? They might stick this down in a list of things and ask you to make the diagnosis. So they might say, mycosis fungoides, for example. Well, it's clearly not that. They might say Bullous pemphigoid. No, it's not that, because it's, maybe it's got some inflammation of the papillary dermis, but it's got dyskeratosis and other things like that. It's not that.
Yeah, I mean, I'm not thinking about like a cutaneous lupus. It just seems too
good. Now, good. Lupus would be in the differential here, but I agree. I don't like lupus here very much. Why don't you like it?
I normally, like if I was thinking about like DLE or something, I would think about more like an atrophic epidermis with
Good.
like
yes, thinning of the epidermis is more common. You can get verrucous lupus in some cases, but usually that's seen with obvious discoid lupus. You'll see a dense lymphocytic infiltrate, superficial deep infiltrate, follicular plugging. So if this were going to be lupus, it would be unusual because you can get thinning of the epidermis where you get just 2 or 3 keratinocytes left. It can be very, very thin. So I agree, lupus would be less likely here, and also no mucin.
Yeah, same with something like DM.
Yeah. DM, lupus, those are basically histologic identical twins. You really shouldn't even basically try to distinguish them histologically. I mean, you can, but you're always going to be wrong. So
yeah. I think similarly, like on the thought of like a chronic fixed drug, if this was like, it doesn't look like there's a ton of scar or like, fibrotic changes in the dermis, but like a recurrent EM of some sort, I guess you could think about, but
Yeah,
it's not really.
but I agree. I don't like that as well. This kind of looks more like a chronic dystrophic interface dermatitis. It's got these long-standing melanophytes, the papillary dermis, still has some dyskeratotic keratinocytes. Even though it's chronic, it's actually still going on. There's ongoing inflammation when you get those dyskeratotic keratinocytes. Well, you may not think of the answer here. This is a chronic chronic graft versus host disease. So this is just an example of the interface dermatitis that you can see with GVHD. So yeah, you wouldn't be expected to just know that. The key, the most important teaching point of this slide is just understanding the interface dermatitis and the pattern. So you're correct on that. That's the main thing you need to know. But if they throw this on a multiple choice and they have chronic fixed drug eruption, just realize that there are several different patterns of chronic fixed drug eruption. You can get this pattern. You can get, if it's still maybe subacute and relatively acute, you can see a lichenoid infiltrate that really looks like very much like lichen planus. And it can be almost indistinguishable from lichen planus in some cases. If you get the really early acute GVHD, that can look like erythema multiforme. I mean, that can give you a vacuolar alteration with more brisk inflammatory infiltrate with not all these melanophages. So that, it kind of depends on which stage you're in. And of course, you can get the chronic sclerodermoid form of GVHD. So this would be kind of more the chronic interface type of graft versus host. So just understand it's one of the interface dermatitides, and it can be either lichenoid or vacuolar. And here we're dealing with more of the vacuolar type. So that's good. So it's a good reaction pattern to recognize. I mean, this is a good teaching case because this really shows that pattern very, very nicely here. Okay, any questions about that?
No, I don't think so. That it wasn't really involving like any of the follicles. I guess there wasn't follicles in there, but I guess it's more acute GVHD. I know we talk about that and it's not specific for GVHD, but
you can get follicular involvement in chronic as well. I just think this lesion, I'm not sure where it was from, but it wasn't volar skin. There may be an adnexal structure right here that's just kind of, there's like probably an eccrine sweat duct, and there's maybe a little bit of inflammation around the periphery. It's subtle, but you can see a couple of dyskeratotic keratinocytes. So yeah, you can, anywhere there's an epithelial involvement, you can get it. That wouldn't necessarily distinguish between acute and chronic necessarily. I would look more at the pattern of the inflammation. Okay, who wants to give this one a go?
I can go. I wasn't really sure what this one was. I thought it was kind of weird.
That's good. That's great. You should say, good, I don't know. I'm going to learn from it. So,
but we have a punch biopsy. And on scanning, what stood out to me is that there's something going on kind of in the deep dermis subcutis. It looks like there's a kind of band of something.
So one of the things we do at low magnification, again, you don't have to do it every single time, but sometimes it's kind of important to do. You say, well, what part of the body are you on? So tell here what part of the body you might be on.
I mean, it looks like there's
not a lot of clues up here,
potentially.
Right? Not much clues up here. But let's look at this area. What do we have here?
I thought that was cartilage.
You thought correct. You thought correct. So when we're in the field of dermatology, at least, we're not an ENT or whatever, when we hit cartilage, there's not too many places that we can hit cartilage, right? Where are a couple of places that we strike cartilage when we take a deep punch biopsy like this?
I mean, I would think ear, maybe nose.
That's kind of it.
Yeah.
If you hit it occasionally, maybe you'll do a deep shave of somebody's papule, maybe on somebody's finger, and you'll hit some cartilage there, and maybe it's an osteochondroma or something along those lines. Maybe you'll do a mixed tumor and there's cartilaginous metaplasia. But basically, you're right. You're going to be the ear and the nose, pretty much, unless you biopsy somebody's, their neck and you accidentally hit their larynx. That's going to be an emergency. You don't want that. So no, this is probably the ear or the nose. Now, if you wanted to choose one of those two, which would you favor?
Mm, uh, difficult.
But what's a clue I'm showing you in this field right here that would favor one side over another?
I think it's little hair follicles. Yeah. So
It's got a few hair follicles. What does it sort of not have a lot of?
like sebaceous.
Yeah.
Since I think the
You
ear
buy
then is
somebody's
less
nose.
sebaceous than the nose.
Yeah, you buy
Yeah.
someone's noses, they have tons of sebaceous glands there, right?
Yeah.
You just see a couple and you got cards saying, that's probably not the nose. It's more likely the ear,
Yeah.
more likely the ear. Okay, good. So we're dealing mainly with a process involving the cartilage of the ear. Now, what does that trigger in
Like
your mind?
CNH.
Yeah. Okay, good. So that's a very good point. When you think about that's one of the reasons why, these little stupid things we do, like what part of the body you're on, they can limit your differential diagnosis a lot.
Mhm.
So how many diseases in derm do we have that involve the cartilage of the ear? I mean, you can name them on one hand, right? There's not many.
Mhm.
Love it. When you get a low number of diseases that we have to choose from when we're dealing with a differential diagnosis, right? We don't like 1,000 things. We like 3 things, 4 things.
Mhm.
So what are about 3? Name a few. Somebody said CNH, right? That's one.
Yeah.
What are a couple of other things that you think about when you think of the cartilage of the ear?
Like polychondritis or relapsing chondritis.
Yeah, relapsing polychondritis. What's another one?
Those are my main two. I think you can get like weathering nodules that are just
Weathering
benign.
nodule. That's good. What is a weathering nodule, by the way?
It's just like these little sort of whitish, sort of regular sized bumps that people get around the helix and like older men from
Yeah.
chronic sun exposure.
Not always older men. A lot of times in Europe, a lot of women get them. Nuns get them. They're kind of related to chondro in a way. CNH. They're basically trauma, and the trauma is not as much pressure as much as like cold exposure. Nurses that wear those, they used to wear the white wimples, and nuns, they can get weathering nodules. It's not really the same as chondro where you're sleeping on it or you're putting a hearing aid in, but if they kind of get sort of a different type of rubbing trauma that's more chronic, they can get weathering nodules. And you biopsy that, you'll actually see some sclerosis of the collagen. It kind of almost simulates LSNA a little bit. And then there's one other thing.
Like pseudocyst of the auricle.
Yeah. So how many other things? Can you think of too many others?
No.
No. So you really only have about 3 things to choose from.
Mhm.
So of those 3, which do you like the best?
Well, it doesn't seem very inflammatory, right? Like I did not see inflammation. So I think relapsing polychondritis is less likely because that's inflammatory, and I think there should be like neutrophils.
Yeah, that militates against it because we don't see any inflammation. Yeah, relapsing polychondritis, in fact, one of the criteria for that diagnosis histologically is you need to see inflammation like lymphocytes and sometimes neutrophils actually in the cartilage. If you don't see those cells in the cartilage, you ain't going to make the diagnosis of it, at least in an acute stage. And when it kind of gets to a later stage and they get the floppy ear, you may just see there's no cartilage left. It just turns into fibrosis and there's no inflammation when you have a late stage lesion of it. It may not be easy to diagnose at that point. It's more of a clinical diagnosis. What about CNH? Do you like that here?
I was actually thinking that should have more sort of inflammation and more like changes in the epidermis, upper dermis.
Yeah, exactly. Basically, all chondrodermatitis nodularis helixis it's prurigo nodularis on the helix, on the ear.
Mhm.
And it's basically, you'll get thickening of the epidermis, you get usually a little erosion or ulceration. Basically, just think you have cartilage and you don't have a lot of space between the cartilage and the skin overlying it. And if you put pressure on that thing, it necroses that epidermis pretty quickly. And then you get the fibroblast and the changes right over. So it's almost like a sandwich effect You're basically putting that skin in a vise between pressure going on from out here and then the cartilage pushing up from here. So you'll always see epidermal changes in that. So the fact we see none here, it can't be that. So that's excluded. So that leaves our one last potential diagnosis, right?
Yeah, so I favor pseudocyst of the auricle, and especially because it looks like this could be curving around to make sort of a pseudocystic structure. And I think some of that, like the mucin or whatever, is supposed to be inside of the pseudocyst. It was hard for me to tell if it was just like degenerated fat versus more mucinous material.
Well, you know what it actually is? The mucinous material is basically the hyaluronic acid that forms the cartilage that gets degenerated because of also pressure. But it's a different type of trauma and pressure. You know, this is kind of like somebody gets hit in the ear with a baseball bat, or they wrestlers get this. You know, this is actually cauliflower ear is what you're looking at here. Basically, you lose the substance of the cartilage. It turns into this oily material that you're looking at right here, usually not with a lot of inflammation, interestingly enough. They don't really get a lot of inflammation. There can be some, but it's not nearly the amount of inflammation you see with relapsing polychondritis. So this is more just kind of like an ischemic traumatic insult to the cartilage. The chondrocytes die, the hyaluronic acid degenerates, this stuff turns to oil, and it gets basically reabsorbed and turns into fibrosis here, and then your ear gets smaller and it gets lumpy and it looks like a cauliflower. And so that's actually what this is. It's actually not a bad name because it is not really a true cyst. It's not really an epithelial line cyst, but it gives you the cystic degenerated area of the cartilage here. So that's exactly what this is. And probably the most important thing on this is that if they're going to test you on a board, they're for sure going to put on their relapsing polychondritis as a differential for you. Okay. So just notice that this has no inflammation here. And often relapsing polychondritis, the loss of the cartilage it's coming from out here. The inflammation goes from the outside. These blood vessels and whatnot are here. They're not in the middle of the cartilage of your ear. They're sitting on the outside. So the inflammation comes in this way and gradually destroys the cartilage from outside in. This thing is inside out. It's basically caused ischemic degeneration of the cartilage, and then it gets replaced. And if you ever see a patient in the clinic and you say, well, this looks like it might be a cyst, let's put a needle in that, or let's put a 15 blade in it or something, you'll get an oil that comes out of it. It looks like, you know, motor oil. So but anyway, this is pseudocyst of the auricle. So that's good.
Awesome. Thank you.
You're welcome. Okay, this is a great one also.
I can take this one.
Okay, good.
So you can see, yeah, like basically a large proliferation of these like pink cells that look pretty monomorphic and basically like contiguous with the epidermis.
Right, so neoplasm.
Mm-hmm.
Okay, benign or malignant?
It looks benign. It looks well circumscribed, symmetric. It's not infiltrating.
Perfect, exactly. Small, symmetric, well circumscribed. Epithelial or non-epithelial?
It looks epithelial to me.
Good, good. What type of epithelium?
That's a good question. You know,
Well, you're going to answer the question.
Yeah. I kind of feel like, you know, just like on my differential, I'm like thinking, you know, like adnexal structures, just kind of like the monomorphic.
Good. Adnexal structures. Okay, now we have several of those in dermatopathology, right?
Mm-hmm. So, yeah, I think, you know, between, I mean, yeah, not really like sebaceous, but between pilar or, you know, like the type of sweat gland neoplasm.
Okay, so let's back up and unpack that a little bit. So we've got follicular, which is one of those. We've got ecrine, I think you mentioned. And then did you say apocrine also? Sebaceous. So we have follicular, sebaceous, and ecrine is what you said of those three. Now, when we think about a hair follicle, and that's why it's kind of important to at least know the basic anatomy of hair follicle. I don't want you to become like a, you know, an anatomic microscopist necessarily, but you do need to know the basic three basic areas of the follicle, and then the little fourth area that's kind of interesting that can give rise to all sorts of interesting little neoplasms as well. So of the three main parts of the hair follicle, if this were going to be follicular, which of the three areas would you think this would be recapitulating?
Do you mean like of the like infundibulum or like that kind of thing, or are you saying like inner root sheath, outer root sheath?
No, well, all the above. So you have the infundibulum,
Mm-hmm.
little funnel that's lined by stratified squamous epithelium. Then you have the isthmus,
Mm-hmm.
where you lose that stratified squamous. It starts kind of going this transition zone where you get kind of that glassy, thick basal membrane zone around that area. And then you get the inferior portion, which is where all the kind of cool stuff goes on. And the inferior portion, you get the internal root sheath, the outer root sheath, you get the bulb of the hair follicle, you get the follicular stroma, so all those various things. So which part of that hair follicle do you think we're looking at right here? Or maybe we're not even looking at a follicle, but if we were looking at a follicle, which part do you think we're looking at right in this field right here?
I would think about the infundibulum, or like, I mean, I don't know. I guess I'm trying to think of things that kind of give you this like glossy pink look,
Well, what about these cells here?
or like glycogenated, I guess.
Yeah,
Oh.
glycogen. Good.
Oh, okay.
Good.
So is that the outer root sheath?
Outer root sheath. Excellent.
Got it.
Outer root sheath. Fantastic. And what's the other name for that outer root sheath?
Oh gosh, I'm blanking on that. Well, oh, do you mean like, well, are you saying for like the different?
Well, I'll give you a clue. So, okay, so limb, like a limb, LEM, that kind of thing.
Oh, like
sheath.
I see.
Yeah, and trich means hair.
So like tricholemmal.
Yeah, tricholemmal. Good, excellent. So tricholemmal or the outer root sheath. So that's basically what this is differentiating towards. These are some of the little outer root sheath follicles that are kind of the germinative follicles. Oh, there's a mitotic figure. Does that mean this is cancer?
Sorry, what was that last question that you said?
I said there's a mitotic figure. Does that instantly mean this is cancer?
Oh no, I
No.
would think that's okay for this.
It's totally okay for this. And first of all, notice it's a bipolar mitosis, which is normal. When our basal cells undergo mitosis, they don't give these bizarre, Mercedes-Benz like mitoses. So, but yeah, this is a germinative epithelium. The second most rapidly proliferating structure in your body, obviously, is first of all your bone marrow. Second is your hair. So that's when you get chemotherapy, your hair falls out. So it's normal if you're looking at a hair follicle tumor to see some mitotic figures in there. In fact, if you don't, maybe the person's not growing as fast as they should be. Their body isn't turning over as fast as it should. Maybe they're dying or something. So what's the diagnosis here?
Trichilemmoma.
Good. Trichilemmoma. A lot of people also refer to this as a tricholemmal verruca. So if notice, it almost looks kind of like a wart, doesn't it? If you kind of look at it at low magnification, it's got the papillomatous features here. So that's another entity. Now, so let's say the board shows you this, and they expect you to get the answer pretty quickly. What might they then ask you about as a second order question?
Like maybe like syndromes that are associated with
Yeah,
it.
they love to do that. I mean, they're pretty predictable, the board. They're not gonna, they don't think outside the box. They think very much inside the box. So they're gonna say, okay, this entity is most commonly associated with which of the following syndromes. So what are they going to put down there for you to choose from?
So this one I think could be associated with Cowden's.
Good, Cowden's. And then they might, ask you perhaps some of the things that go along with Cowden's syndrome. So make sure you know the syndrome. So those are, they're going to ask them. They're easy to get. It's pretty simple to memorize those. Now you need to know the genes associated with them, the P10 mutations and those various items. So I'd recommend just boning up on those. Now, the one thing that you might, if you're looking at this, hopefully able to recognize this is tricholemmal differentiation. These are glycogenated cells. Some people sometimes think that they get confused with these in sebaceous cells. Okay, sebaceous germinative cells are usually more basophilic and round. They're darker, and if you look at the clear cells of sebaceous, they have kind of a little crenated nucleus with these little radiating gossamer strands of nucleoplasm that almost like the, they're holding the Hindenburg down a little bit. They're these little strands that kind of, they kind of radiate off the nucleus to the outer part of the cell membrane. So you can tell the difference between a sebaceous cell, they have a bubbly cytoplasm, and a cell like this, it's a tricholemal cell that is glycogenated. So this would be PAS positive, diastase sensitive. So that means if you put this enzyme in to digest the glycogen and then you do a PAS stain, it's going to be negative after that because this is glycogen and it's not lipid. Okay. So just make sure you can tell the difference between lipid and glycogen and sebaceous and tricholemal. Okay. So good. All right. This is a good one also.
Oh yeah. Okay. So looking at a hair follicle, there's some orthokeratosis. There looks like there's maybe a subcorneal blister, as well as an intraepidermal blister, as well as some papillary dermal edema.
Okay. So you're talking an inflammatory process here, obviously.
Mm-hmm.
And you've already mentioned a couple of reaction patterns. So intraepidermal vesicle, papillodermal edema. What about the infiltrate?
I think it was mixed.
Okay, probably was mixed. What are some of the cells we see here, low magnification?
Those look more like lymphs, but then I
Good,
think if I got, yeah, but I think a little bit closer, I saw some EOs.
There probably were some EOs here. And what's the pattern of the inflammation?
Like superficial perivascular.
Yeah, more superficial mid, perivascular, a little bit of a perifollicular inflammation as well. But the action seems to be going on in the epidermis and beneath the epidermis. What about the cornified layer?
I mean, it looks like it's mostly normal, like ortho.
It's vascular up here. What about here?
Yeah, and I didn't know if that was just changes because there's like if that's like from this like subcorneal, like from the bulla within the, yeah. So I didn't know. I didn't know if that's like keratosis or because of the bulla.
It is. It's good. I'm glad you noticed that because I want to really point it out to you. It's a clue. It's a clue to the diagnosis in this case. You've got parakeratosis, and then you've got orthokeratosis overlying it. So this thing would probably not be too scaly yet. It's going to get scaly pretty quickly, but it's got what we call a sandwich sign. We've got a vascular cortical layer, parakeratosis beneath it, and something likes to live in that little interface between those two, and it can sometimes induce a pretty prominent inflammatory infiltrate with these changes. So what's this right here?
Oh, sorry, it just moved. It's like spongiosis.
Yeah, this is spongiosis, and that's actually formed a spongiotic vesicle. So it's actually formed an intraepidermal blister, a spongiotic blister. So if you saw this thing clinically, it'd probably be these little tense papullovesicles that maybe hadn't become really scaly yet. And then you give it another couple of days, those things are going to pop, and then you're going to get a central area with a peripheral collarette scale. So whenever you see like a collarette scale, that's almost pathognomonic for at least a spongiotic dermatitis. That was relatively acute, and then the spongiotic vesicle ruptured, and then you get the collarette scale of the periphery. So that's a classic example of that. We've got some cells in this area also. What are these cells up here?
You got some newts.
Good, neutrophils, neutrophils. So, and then we have the papillary dermal edema here, which is just because of all the inflammation over here and still some spongiosis. And we've got this little so-called sandwich sign. So any ideas what the diagnosis might be?
It's bullous tinea.
Yeah, bullous dermatophytosis. Good. This is a classic example of bullous dermatophytosis. Okay. Now, what are some of the, why did you think that? Why did you actually arrive at that diagnosis?
Because there was 3 different locations for like edema and like vesiculation.
Well, could you see this in an acute allergic contact dermatitis? Could you see
Yeah,
this
that was all.
pattern in?
That was also on my differential, but then
Yeah,
I felt like
you
I
could see it. That's right. So in other words, a differential of this would be acute allergic contact, nummular. Probably wouldn't put dyshydrotic since it's not from the volar skin. Maybe a florid bullous drug eruption, maybe a photoallergic contact dermatitis. Bullous tinea is in the differential. So as opposed to our case of the Pseudocyst auricle, we only have 3 things or 4 things. Here we've got about 50 things that can do it. So you have to use additional clues here. So what helped you? So you got the diagnosis. You didn't do a PAS. So how did you arrive at the diagnosis?
I thought I saw like stuff in the stratum corneum. I thought I saw like
Okay,
those
good.
like translucent.
Why did you look there? Why?
Because if I don't know for sure what it is, I like zoom in real close and look at everything from top to bottom.
Okay, that's one. But let me give you another good reason for why. So if you see neutrophils in the cornified layer, always think of fungus. Boom, always.
Yeah.
Now, it may not always be. It could be psoriasis, it could be pityriasis lichenoides, it could be Bullous impetigo, but you should always think of fungus when you see neutrophils in the cornified layer. And so good. So you knew to look up there. That's great. But if you want to be kind of a targeted look, you want to do that. Another clue is this sandwich sign. The fungi, and there's some fungi. There's one right here. You see it right there, that clear area. Here's another one here. It's, it doesn't project that well on the microscope, but there's a hyphal element. There's another one over here. This thing is loaded with organisms, and they like to live right here. That's where they live. They live in the sandwich. So you got a piece of white bread over here. You got the bottom white bread, and it's with peanut butter and jelly. I mean, they like to live right in this little interface between the parakeratotic cornified layer, the crusted area, and the basket weave cornified layer overlying it. So whenever you see that, you should say, I'm going to make sure that there's no organisms in here. And boy, there's tons of them. See these here?
Mhm.
Even in this projected thing, this is loaded with it. And so, yeah, this is Bullous dermatophytosis. That's good that you got the diagnosis. So just, in order to become, to graduate from being a shotgun shooter to a rifle shot sniper killer, think about these other clues that show you when to look up in that area. So if you see like this basket weave overlying the parakeratotic, you should think instantly about the possibility of tinea. Sometimes you don't get a lot of inflammation, interestingly enough. This guy has got lots of inflammation. If you were going to choose a fungal organism here, now Dr. Aluski still submits questions for the board. She loves fungi, so make sure you know a little bit about fungus. You don't have to become a mycologist, but fungus is fun, and so I recommend knowing at least a little bit about it. Which organism is going to be most likely to give you this amount of inflammation with all the spongiosis and papillodermal edema and scale crust and all this kind of stuff? What organism is going to be most likely to cause that, or what genus of organisms?
I think it's the like zoophilic.
Yeah. either the zoophilic or the geophilic organisms. So in other words, organisms that generally like to live in the soil and maybe affect human beings secondarily, or maybe they like to live in animals and then we get infected secondarily. The anthropophilic ones, like T. rubrum and T. tonsurans, especially T. tonsurans on the scalp of kids, I mean, they just get that little black dot tinea capitis and they come in, they may not have any inflammation at all, but if they get microsporum on their scalp, like M. canis, maybe a little little cat, little kitten, and then, everybody in the family gets a fungal infection. Those are floridly inflamed. And those are the ones that generally tend to give you the favus and, those kind of bad tinea infections when they're really inflammatory. So just in general, the less well adapted they are to people, the more inflammation they tend to cause. So this would, you maybe think about the possibility of one of those organisms as opposed to just T. tonsurans. Okay, great. Yeah, you probably do see EOs in tinea. It's not uncommon to see eosinophils. That's not something that you read about in the textbooks, but tinea, boy, they can give you tons of eosinophils also, not just polyps. Okay, this one's a pretty simple, easy one.
Okay. This was I thought a neoplasm.
Good.
And I don't know if it's tracking down this like follicle or if it's just acantholytic in the epidermis there, but it gives that like villi sort of look to make me think about Warty dyskeratoma.
Good. Okay, you're right about that. Sometimes getting an instant Schnell diagnosis is great. I do it every day here hundreds of times. But in other cases, you might have to back up on a board examination because they might ask you some questions here that you start scratching your head about. So yeah, this is a small, symmetrical, well circumscribed. It's an endophytic process. It looks like a cyst. And then you say, well, you know, we always ask ourselves, if it's a cyst, what's the lining of the cyst? And so as we look at this, you thought the lining was?
It looked like villi to me. Like I almost could have convinced myself that there was like some not ciliated areas, but like almost looked like goblet cells, sort of.
Oh boy. Okay. Well, you're like a board writer's dream. Because they're gonna say, oh, good, we're gonna put stuff on here that's gonna confuse them. But I want you to notice, so this is the classic situation of reaction pattern, epidermal reaction pattern. Okay. And there's about 15 or 20 of those that you need to know about. So when we're looking at the reaction pattern, notice these cells are falling apart from one another, right? They're falling apart. They're floating freely in this space here. So what do we call that when the cells are floating freely in a space like this?
Like, are you talking about focal acantholytic dyskeratosis?
Yeah. So these are acantholytic cells. What are these cells?
Those are the dyskeratotic
So
ones.
the dyskeratotic cells. Good. So this is the reaction pattern of focal acantholytic dyskeratosis. Now be careful of the villi business. Well, what's another disease where we talk about, quote, villi like this that can fool you?
Well, actually, when I first thought of it, or when I first saw this, I thought could be like an HPAP almost. But anyway, I don't know about specific villi diagnosis.
Well, you know, you hear the term villi when they talk about pemphigus, right? So
Yeah.
you want to, so they might say, you know, pemphigus vegetans. They might put that on the exam, say, yeah, they're villi here. Gosh, you know, don't use the villi as a criterion. The main thing you want to do is look at this thing and say, okay, it looks like a cyst at low magnification, number one. Number two, we always look at the lining of the cyst, okay? And we see here that's lined by these cells that are acantholytic, and then we see the dyskeratosis. We see the corones here, the round bodies with the, you know, the pink cytoplasm and the pycnotic nuclei, so that's a dyskeratotic cell. We see the grains, the parakeratotic, dyskeratotic, parakeratotic nuclei up here. So this is focal acantholytic dyskeratosis lining a cyst. And yeah, they get these villus papillomatous projections sometimes. They don't have to, but they often do. And this is a classic example of Warty dyskeratoma. So they might throw out some of the other acantholytic disorders to try to fool you. They might do something which is even more diabolical and put Grover's disease down or Derrier's disease down. Now that really would be kind of quasi unfair, but if they say the best diagnosis of this solitary lesion would be, and if they put the other acantholytic dyskeratotic conditions down, you shouldn't go there. You should say, yeah, well, we know those can also cause FAD, but this is a solitary lesion. So it's going to be a Warty dyskeratoma. It's not going to be Derrier's, for example, which have thousands of lesions in a different distribution. It's not going to be Grover's. So the main thing here, the teaching point is recognize the FAD and also recognize that it's a cyst. Okay. They said goblet cells, those should have mucin in the cytoplasm of the actual cells. So make sure you go back and look at a cell like in the salivary gland or something like that, or a GI biopsy or something, there's no goblet cells here. There's no mucin here. Cilia are going to look like little gossamer-like sort of strand-like structures off the surface of the individual cell. I don't really see any of those here either. And you're not going to see, in the putting the constellation of everything together, you're not going to see the dyskeratotic cells. So just make sure you get that. This is board fodder 101. They're going to ask you the concept of the epidermal reaction patterns. You just may as well go ahead and just start studying for it now, because they're going to ask it. So by the time you get there, you're going to be bored with it. You're going to say, I know they're going to show this. I don't insult my intelligence. So make sure you know these epidermal reaction patterns, and you know this focal acantholytic dyskeratotic pattern, where that can be seen in all these entities we just mentioned: Grover's, Derrier's, Vis, etc. There's only about 5 of them. Okay, any questions or comments about this? I think our time is up. So thank you guys for joining this morning, and we will see you next time we do this, and I'll see you guys at Grand Rounds tomorrow.
Thank you.
Yeah.
Yeah.